these two patients, the ones that worked, the only pain patients that worked, they have the same kind of pain. And that lady who's coming in now, she has the same thing. So he asked her in, and she told him about, the pain. And then he just looked at me, and then he looked at her and said, you know what, we will have a treatment for you. It's called deep brain stimulation.
Welcome to Stimulating Brains.
Hello and welcome back to Stimulating Brains episode number 27. It was my great pleasure in this episode to talk with Marie Krüger, who is the director of the stereotactic unit in St. Gallen, Switzerland. So she's leading the deep brain stimulation and stereotactic surgery program there. But Marie's also on her way to London. She's going to join the team there at UCL in Queensquare as a functional neurosurgeon. Marie trained in Freiburg, Germany under Volker, Coenen and Reinacher, and she was instrumental in helping to create algorithms to detect segmented electrodes together with Reinacher, and then also use these segmented electrodes in multiple research projects when these electrodes were still new, but also now in very creative ways. For example, one of her key projects currently is to use these segmented electrodes to target 3 intersecting thalamic nuclei, and then to use the steering modality to find out which of the nuclei is best to treat intractable dental pain. When Marie did her fellowship with Chris Honey in Vancouver, she also worked in spasmodic dysphonia, and I think it's really impressive how much experience she has already gathered in actually quite little time. So thanks again for tuning in. Marie Krüger, Stimulating Brains. Marie, it's a great honor and pleasure to interview you. Thank you so much for taking the time to take part in this. I will have more formally introduced you already by now, so we can directly start. And as you probably know, I always start with an icebreaker question about non-scientific things, and I know you will have great answers. So any hobbies or things you do when not doing surgery?
I don't know if I have a great answer to that, but I have a very straightforward answer. I think I love everything outdoors and being active outdoors. So hiking, biking, swimming, snowboarding, cross-country skiing in winter time, anything that gets my body moving and maybe also to get my mind at rest a little bit. So it really helps me to clear my thoughts. And I have this interesting passion for swimming in freezing cold lakes in winter time. So I've been doing that quite a bit here in Switzerland now, and it always gives me a special thrill. So I enjoy doing stuff like that. Yeah.
Is that really like ice? Would you even go, make a hole in the ice? Did you do that?
Sometimes you kind of have to crack it open a little bit, but then I really just go in and hang on to something and then climb out. But usually I usually go to a little bit like a bigger lake where that doesn't freeze, and then you just go in and swim a little bit and go out. And so that's maybe an uncommon hobby.
Yeah. So meaning mountains and outdoors. I know you snowboarded a lot in Vancouver. Is that still a passion?
Yeah, especially. The funny thing about Switzerland in lockdown was that everything was closed, but all the ski areas were open. So I did that a lot during lockdown. So you would be in a gondola with 80 people during lockdown, but they were fine with that. You can't take away the right to ski in Switzerland. So that was funny.
Great. Yeah. Love that. Okay, so talking about the science and also medicine, who were key mentors in your career or turning points, to get where you are now?
So I think I did have quite a few mentors, and I always underestimated the importance of mentors just until now, actually. I think I had mentors that were very different mentors at very different stages in my career. And I would really like to quote a little like a quote from one of my favorite books, the 1% Rule by Tom Baker. And because when I read that, I thought, well, that really, really fits so well. And it goes something like, mentors come in all shapes and sizes. Mm-hmm. Some last for a day, some last for a lifetime. What matters is not the duration, but the impact. And that was very true for me and some of the mentors I had. And so one of the mentors is certainly Peter Reinacher. He's one of these lifetime mentors, I think. He inspired me to do research. He was the first, I think, surgeon I met who really was passionate about what he was doing and passionate about research. He just made it fun, but at the same time, it was very meaningful, you know. Then Volker Coenen, he was one of these door openers. He opened the door for me, I think, you know, to go to Vancouver to do the fellowship. But at the same time, he also encouraged me to go through, and he kind of gave me that feeling that he believed that I could do it when I wasn't so sure. So I think that was a very important, it was one of these turning points in my life as well. Yeah. And then, of course, Chris Honey in Vancouver, where I did the fellowship, who just taught me everything about DBS that I know, and research and all that. So, I think it's so important to have mentors. I don't think I would be anywhere close to where I am now without these people, and there are so many more, but I think these were the key ones. People.
Did you have one that just lasted one day, like from the book, or the one day encounters?
No, not necessarily just one day, but maybe someone who did one move. You know, like my English teacher who enabled me to go to Australia, who gave me an address. And then I went to Australia and did, you know, a few months there, which was a big step. And I think it started, or a lot of things started from there. So not just one day.
That's a great example, though. Yeah, but so I get the point, right? So a single incident that made a big difference. So I'm sure that happens a lot, and maybe more than we even realize.
Exactly.
So, great. So you did complete your neurosurgery residency in Freiburg. You mentioned Peter Reinacher and Volker Coenen, the two, I think, neurosurgeons there. Are there more? Like, you were there, but is there anybody else doing functional only in Freiburg currently?
So there are now 4 neurosurgeons. Okay. Bastian Zayens and Nadja Jagd. So 4 neurosurgeons and the neurologist. Yeah.
Great. And then we both studied in Freiburg, so I thought to mention that. That's how we met first time, indeed, in med school. And I don't think many people would know this, but for historical reasons, Freiburg and then also Cologne are the only 2 universities in Germany, or university hospitals, that have a dedicated chair of stereotactic, so functional neurosurgery, which is more or less then independent from the general neurosurgery department. Of course, not completely independent, but, you know, it's a full chair, a professorship, and a Lehrstuhl, we'd say in German. So did this history that Freiburg had, you know, a chair for stereotactic, play a role in your choice to become a functional neurosurgeon, or not really?
So I think when I was there, I wasn't really aware of that special situation. But maybe indirectly, it did have an impact, because it's one of these places, or one of the few places, where you actually get to see functional neurosurgery, like all of it. And it definitely helped me to realize that this is what I want to do, to have this amount of impact and see its full potential. So indirectly, I think it did play a role, but while I was there, I actually wasn't aware of that.
So any other reasons why you chose functional neurosurgery and not, say, vascular, or even neurosurgery in general?
So neurosurgery in general, that would take a long time to explain, I think, or then maybe not. I just, when I was a little, like a young girl, I had an injury on my foot. I couldn't walk anymore when I was 15. And that was had such an impact on my life to realize how important health is. So I knew I wanted to become a doctor. I actually didn't think I was smart enough to go into internal medicine or do anything like that. So, and I loved doing stuff with my hands. So I kind of knew I would have to become a surgeon. And then I wasn't good at school at all. I only played soccer my whole childhood. So I just had to improve my marks. So I had to sit down and I started reading about the brain and how it works to improve my marks. And I did that, and I got really fascinated by the brain. And so it kind of all came together, surgery, brain, and all that. So I chose it as a clinical subject in the first year of med school. So that's basically how I got into neurosurgery. But then when I really liked neurosurgery, but then we had to do this rotation into the functional department. And we had to. I didn't really want to, but as soon as I was there, I just fell in love with it, and I can't pinpoint it down to one aspect, but I think it's functional is a nice combination of neuroanatomy, science, and very delicate surgery. Yeah. I also have to admit I like the slower pace, because general neurosurgery is all about emergencies and everything has to happen at the same time. Whereas in functional, you need to take the time to think about the patient and to plan the surgery very well. It's not just you should, but you have to. And research, I love research, and it's basically part of it, right? I think you can't do functional without research. And then it's just so rewarding to be in the OR, for example. You're in the OR with a tremor patient. That's my favorite indication still. And then you do the surgery and then the tremor just stops. And I don't think I'll ever get tired of that. That's such a fascinating thing. And you know that you actually did that. And, and you did it. And the fact that it was so hard to get there and to learn everything, and the fact that you had to go through so much makes it even more rewarding. And, going home and you've just changed someone's life for the better. I mean, what better job in the world is there, right?
I can totally dig that. I would say the same, that I'd never get tired of seeing tremor stop with DBS, but I would never be the person to have done it. So I could totally see why, that's the extra bit. And I think, in fact, Ludwig Zünzel from London mentioned to me that, he got goosebumps in the first OCD patient he did, where that's maybe even, I don't know, changing the psyche or, could. But so I totally understand that. And then also what you said, that it took a long time to get there, and then actually being able to do this. That's cool. So I guess a few people would also say that, let's say, vascular or tumor surgery or so would always, you do these elaborate things, but then it only lasts a few months. Would that also play a role, that you can actually in functional do,
Yeah, in a way it does. Way it does. Yes. I mean, it's very demotivating, I think personally, to operate on a patient with a tumor and then you find out that he died a few months later. Whereas the movement disorder patients, you see them, a lot, and they come back, and not all of them, of course, but the majority is. Every time they see you, they're just thankful and happy. And that, again, the other day I had a tremor patient who showed me one of his paintings that he can do again now, and these things. So it's nice. It's not you're not saving lives, but you're improving quality of life. Yeah. And that in itself it's just such a rewarding job. I just love it. I think these are all the reasons for it.
Enough reasons, definitely. So a few years back, you completed a fellowship with Chris Honey in Vancouver. what were the key highlights there? Oh, sorry. Before we go into that, I think I missed the question. So maybe let's talk a bit more about your time in Freiburg. So what were the key points there? What did you learn from Peter and Volker? And can you talk a bit about that time of your career first?
Yeah, like I mentioned before, I think Peter really got me into the research aspect of neurosurgery, and I think one of the greatest projects we did was we tried to figure out the depiction of the directional electrodes, so we could find out how they're rotated. Yeah. And Peter had started to do a lot of work, and then I happened to rotate into the department, and then we continued working on that together a little bit, and we came up with this plaster skull that we filled with jelly to have a realistic brain model. And I remember the two of us, being in his office, filling up this plaster thing with green jelly and then putting it into the CT scanner and the MRI and into the fluoroscopy until we finally figured out, it was Peter who figured out, how to read it and how to do it. And just being part of that was a lot of fun, and it's still important, and it still Absolutely. Has an impact. And it had such a big impact on my time in Vancouver. So I learned a lot about directional electrodes there because they were new and they did a lot of research on them, also from Volker Coenen. And when I went to Vancouver, Canada had just got the directional electrodes because they were released later than in Europe.
Yes.
So they didn't have any experience with them. So that was a big, that was great for me. And knowing how to, I came in, that was the only thing I knew really. But we did a few studies, and we wouldn't have been able to do the studies if we hadn't established the rotational fluoroscopy in Vancouver then. So it was like something I learned in Freiburg that I took to Vancouver, and then we were able to do a few studies. And I think that was the thing that had the most impact, the directionality and depicting it, and seeing how Peter approached, these questions. And I think that
I remember a talk from Peter. I don't know where it was, but where he showed these videos of the rotation of fluoroscopy rotating around the electrode. And I think what I took home is that, it might seem as an easy problem if you rotate around the electrode to see it, but since it's always just coplanar, it is a much harder problem. So it sometimes looks as if they were rotated that way, but it's not that easy, right? So can you talk a bit?
It's not so easy. Well, you have the marker and you have the iron sights, but it takes a while to understand how to read the fluoroscopies. And now the CT method, I think, that has taken over, but it's based on the same principle. I think it was Peter who coined the term iron sight, and who kind of, I think, motivated or inspired the people who were working on the CT project to use the iron sights as well and put it into their algorithm. So that was kind of the base that helped to get everything running then. And so
one other thing that's special about Freiburg that I always envied, also similar centers like Cologne, that you have all these indications, right? So in Berlin we essentially only do movement disorders, or did when I was there, and you had depression, OCD, then of course also the the classical indications. So was that also formative to be experienced or exposed to these projects with the medial forebrain bundle or similar?
Oh, things? Yeah. It was great to be in a center where they were so involved in the depression, DBS for depression, and also speak to Thomas Schlepfer, the psychiatrist. And it was interesting to see how important it is to have both specialties. A neurosurgeon was really interested in this project or in the indication, and the psychiatrist. And I think that's a problem, or that's what lacking in many other places. It was great to see they do everything there.
Yeah.
And that was certainly very inspiring as well. It was a lot of impact.
Great point with the psychiatrist, because I think people like Thomas Schlepper or Jens Coenen, Cologne, who left already, are so rare, right? In not only in Germany but everywhere. I think, remember, Marwan Harris gave a talk where he even showed indirect evidence at some point where the psychiatrists that would engage into functional neurosurgery would be shunned by their peers, not only in Germany but everywhere. So that there's even some sort of push, against that. So, and I think that's a big problem. There's just out, I think, a Nature Medicine paper now to promote more the OCD research and so on. So any thoughts about, how, or for example, I think Marwan would also say that psychiatrists would not go to the surgical conferences, but neurologists sometimes do. I mean, they also don't go enough, I guess. But do you have any thoughts about how could we, foster more or bring these three specialties, but especially psychiatry, closer together?
Oh, good question. So what I did here in Switzerland, we tried to encourage psychiatrists to start collaborating on a project, and I found it so hard. Okay. I think we have to go out there and tell them, here are the options, and encourage them to think about it. I think one thing that might be maybe a key turning point is the high focus ultrasound. Mm-hmm. So you go to psychiatrists and you give a talk on DBS for depression, and they're like, okay, that's nice. But you can see in their eyes, they don't like these wires. They don't like to know, they don't like the idea of adjusting the stimulation where they don't have any clue about. But then at the end, I always show, a potential future would be the high focus ultrasound. And that really gets them interested, mm-hmm. because the idea that they can just send a patient to something that still kind of looks like a non-invasive
looks
treatment.
Like it. Okay.
At least it looks like it. I mean, we all know it's not, but the patient think it's not, and
it's not surgery. And
you send the patient there, they get a treatment, and then you're not stuck with adjusting stimulation and all that. I think that might actually help everyone, just to get them interested. And I remember, I think it was Andres Lozano who said that since they started with the high focus ultrasound in Toronto, they also have more patients for DBS, because it attracts the patients to come to the surgeon and talk about, is there something we can do about my condition? And then I think if, when they talk about it and you explain the options and also DBS, and you show them, and maybe you give them the number of a patient and they meet, and they realize, oh, wow, I mean, it is brain surgery, but it has such a big impact. So I think maybe that will do the trick, hopefully.
Yeah, that's a good idea. So the same here, I think, at the Brigham, that cases certainly didn't go down in DBS. The overall cases went up by by far.
Yeah.
And just giving people choice, makes it more attractive. They can then choose. So sorry that I dwell so much on this topic, but I find it really interesting. And I just interviewed Nolan Williams, who is more in the TMS realm, but he also did a lot in DBS before, scientifically, and he mentioned that maybe one thing that needs to happen could even be that we get a new residency as a brain stimulation doctor, that could potentially even treat across neurology and psychiatry. I mean, certainly not, surgeons do that anyways. You wouldn't really care much, probably, what disease the patient has, but or you certainly care, but no, sorry, I shouldn't have said it that way, but you would obviously you care, but it's the technique is similar. It's what I wanted to say. It's not a completely different type of surgery or so. That's right. What I wanted to say, and I guess mirroring that on a having a brain stimulation or neuromodulation specialty, I at least found it a really interesting concept to think about, because he said that probably with neurology, and he did both residencies. So he has, neurology and psychiatry. And he kind of said that usually you're not fit to treat either of them really well. Even as a neurologist, maybe you're not the perfect DBS doctor already or so. But yeah. Any thoughts about that?
Yeah, sounds like a good idea for sure.
Okay.
But because I know you're going to ask about the fellowship in Vancouver next, and you mentioned that we don't care about the disease or the indication that much, so we didn't have.
I corrected myself.
No, but because we didn't have neurologists in Vancouver, so we really had to care about everything, and we had to. We were the ones to set the indication, and that was great for me as a surgeon to learn how to think like a neurologist. And the same with the programming. So we did all the programming ourselves.
Oh wow!
And that was I'm only realizing now that this was a very, very special situation.
Yeah.
And helped me very much to think a little bit more like a neurologist, and be just as meticulous about indication as we are about surgery. Because you can be the greatest surgeon on the planet, if the indication isn't right, it won't work. We all know that. So
that's so interesting. So let's talk a bit more about Vancouver now. So you went to work with Chris Honey, I think about a year, a bit more probably, to learn with him, and it was a real fellowship just for functional. Yes. Can you talk a bit more about the general setup, but also if you want to elaborate on that, why were there no neurologists? And I agree, this is a great learning opportunity to broaden.
So the general idea of the fellowship was basically that there's only one fellow who does everything, but at the same time, of course, you learn everything. So I like to call it the toughest and the best year of my life. It was certainly challenging. It was because from one day to the next, so you're overlapping with the previous fellow for a month, but then you're on your own. And so I started in July, and we were overlapping. And then in August, Chris Honey goes on holidays for a month, and you're in charge for everything. So you'll get all the phone calls, and they are looking after 1,500 DBS patients, because they're the only center in all of British Columbia. So that's quite a lot. And I have to say, that was quite challenging. We didn't do surgeries that month, but you had to be there and answer questions. But in general, the idea was that the fellow would really learn everything. His idea is that he would train a fellow who could then go back to his own country and run a service there. Okay. And not just do the surgery and get the electrode down there, but be able to set the indication, be able to do the surgery, have a look, localize the leads, make sure they're in the right spot, program the patients, follow them up, manage everything, every emergency, and it's just everything. So it was only functional and a little bit of what we had to do on calls, but that was it. General neurosurgical on calls. And then we did MVDs, radiofrequency ablation, cordotomies. So it was movement disorders and pain, and these different techniques. But the main focus was certainly on DBS. So it was a very, very steep and learning curve. And I was heavily involved in research. We worked on, I think we published 10 papers together. Wow. Out of 1 year, which I think is great. And so I think I got a lot out of it. But like I said, it was the toughest year of my life as well. It was also really tough. Yeah.
See, I love the interdisciplinarity of the field, but I could still see how this is, the perfect place for especially a young neurosurgeon maybe to learn things, because you essentially close the loop, right? If you stimulate the patients, like program the patients later, I guess often the typical canonical criticism maybe of a neurologist could be, I'm not saying it is, but could be to the neurosurgeon that, they put the electrode down there and then they close up and they're done with the case, right?
Right.
Which is also often not true, I know, but that could be the criticism. And then, you kind of never get the real feedback, like long-term feedback of, did you do a good job even, right? So if the neurologist is not transparent, or it's just not, it's not all from one hand, but it seems like there in Vancouver, you had that opportunity to do the programming and so on. So you also took care of 1,500 patients, really did the programming there as well?
So they have 3 DBS nurses, and now they're getting a 4th one because it's just getting bigger and bigger.
Yeah.
So I could sit in with them and learn how to do the programming. And I did a lot of programming with the directional electrodes for the study patients as well. Mm-hmm. So for me, it was great to have this closed loop. Yeah. And when I came to St. Gallen, I actually said, I insisted on having this closed loop, mm-hmm. Because I ran the functional program there, and I wasn't the only functional surgeon, so I thought I had to make sure that what I'm doing is right. So I wanted to see every patient before. We still always discuss every patient in our meeting, and only if everyone agrees, this is what we want to do, we go for it. I plan the surgery, I look at the post-op fusion, and then I insist on seeing every patient at least once, if not twice, to see what is the result. And I have a little book where I write down, special things. Oh, this was a little, this electrode was a little bit more lateral. Yeah. Let's see if that worked. And I think that really helped me to get better and better. Yeah. And also, to make sure that, what I'm doing is right. And I personally think that's the way you should do it. But I know there are centers where the surgeon is only there to do the surgery. Yeah, I guess it works, but I mean, we spoke about it before, that it's really, I think the best situation is when you have a passionate neurosurgeon who understands the neurological side, and when you have a neurologist who's also interested in, where is the lead, where, and also wants to see the result of the surgery and is not just programming in the dark. So
absolutely. Yeah, it goes both ways. I totally agree. And I did sit in all the plannings in Berlin at the time there myself, just out of interest. And I think over time, they became a bit more interested in my opinion as well. So, it became a multidisciplinary thing. Obviously, the surgeon had the last word. He would, then go ahead and do the surgery. But I think that is truly the way to go. But of course, it's often a resources question, right? It's additional time that
you're right. Yeah, you're right. Yeah. But I'm like, in the perfect world, I think that's how it should be.
Yeah. That's good. Okay, so speaking a bit about science, so together with the team in Vancouver, you worked on a prospective randomized double-blind crossover trial on thalamic deep brain stimulation for spasmodic dysphonia. It's not your own big story, which we'll come to, but I think it's the big story of Chris Honey a bit, or at least one of his stories. So could you tell us a bit about what spasmodic dysphonia even is, and a bit about the findings of the study?
Yeah, so spasmodic dysphonia is a neurological disorder that affects the speech and the voice of patient. It's also called laryngeal dystonia, and it causes the vocal folds to contract involuntarily. So patients would speak like this, right? So the vocal folds always shut, although they don't want that, and it's really hard for them to speak properly. And so, it was Chris Honey who found that VIM DBS is a treatment for spasmodic dysphonia. And since you mentioned it, I think the most hilarious thing about it is the story on how he found out about it. I mean, do you know how?
I don't know.
Okay, so I have to tell it, because it's I love hearing it from him, because it's nice to hear it from him. You'll have to hear it from me now. So he said, they operated on patients with tremor who also have SD. So about 5% of tremor patients have SD as well. And they just did their VIM DBS for the tremor, and then the patients came back and they would go, oh yeah, so my tremor has improved so much, and also my SD is gone. I didn't know that was part of the deal, but great, thank you so much. And he would go and he said, so, oh, you know what, I didn't know it was part of the deal either, and I didn't even know what SD was. So he kind of realized that by treating the tremor with the VIM stimulation, you could treat something called spasmodic dysphonia. So he kind of read up on it then. And then I think he made a very, well, he made the right thing. He took a spasmodic dysphonia patient and without tremor.
Yeah.
And the big question, and you look at the literature, so there were very, very few case reports on it, but no one actually went did the next step.
Yeah.
So the question is, it's a dystonia in a way. So you would think the target is the GPI, right? And not necessarily the VIM. So they took a patient and they implanted an electrode coming from very anterior, having one contact in the VOA, which has palatal input, and then one contact in the VIM with cerebellar input. And they just again found that the VIM is the better target.
Interesting.
And then he said, you know what, we need to do a little trial. And so they did this trial, a crossover, randomized, blinded on 6 patients with purely SD, and did a unilateral VIM. Left VIM for right-handed patients, because he also found that it looks like the speech dominant brain hemisphere in right-handed patients gives patients the most benefit for their SD. And then the patients really improved, and the quality of life improved, and now they're working on the next bigger trial. So very exciting.
Very cool. Yeah. So I would have, that's what I would have thought, the VOA, maybe it was just, but you checked for that, or he checked for that. So that's really interesting. Are there mechanistic thoughts about why cerebellar input? Do you know what the thoughts are, or is it currently just
it's just work. So for me, it's just working. And I know Chris Honey has thought about it a lot, so I'm sure he has some answers to that. But for me, it's just working. I actually operated on 3 patients in Switzerland, and it works in German too. So
cool, it works in German too. You also in one study compared bilateral and unilateral stimulation in 2 patients. So that, I think you already alluded to that.
Yep. So before he designed the study, but there were a few patients with both tremor and SD who had bilateral VIM stimulation, and then we did a little trial on those 2 patients. Actually, were 2. One was right-handed, and the left VIM stimulation gave that lady the most benefit, and the other guy was left-handed, and the right VIM gave that patient the most benefit. Ultimately, both sides were, actually the best, but it was very subtle, that additional benefit. So, still also not quite sure whether we should go bilateral or unilateral. But they're doing a lot of research on all these things now.
I guess a bit more your own story, or one of your key stories, is also, as we already talked about, directional electrodes. It seems, just looking over your publications, you worked a lot with that, starting with Peter Reinacher, but then also in your work on pain that we'll come to. I think you did also compare tremor and quality of life in patients with essential tremor before and after replacing their standard DBS, so the omnidirectional system with the directional electrode system. That is quite rare, right? That you would pull out the electrode and put a new one in. So I guess you use these patients as an opportunity to study that, right? If I'm honest.
Yeah, exactly. Yeah. So that was a study that I ran when I was in Vancouver. So the basic idea again was from Chris Honey, but then he let me do it because he realized I knew a lot about the directional electrodes. But the basic idea was we had a subset, or we all have them. The tremor patients that do great initially with the ring mode, and then after 2 or 3 years, the tremor progresses and you just can't get the tremor under control anymore. So we were looking for a solution for those patients. And by that time, the first papers on directional electrodes had already come out, and they all showed theoretical benefits, like, a wider therapeutic window, no superiority in terms of clinical benefits, but these were all newly implanted patients. So we thought, if you have the possibility to steer away from a side effect, and you have an advanced patient, maybe it'll make a difference in those patients. So we chose these 6 patients, and literally took out the electrodes, the old ones, and slided down the new electrodes down the same path. And then we compared the tremor before and after, and found a significant improvement with the directionality. It was 20% in the end, but it did make an impact for most of them, like especially in their quality of life.
And would you say it was because you could essentially, ramp up the voltage more without side effects?
Yeah. It was basically what we did is we put most of them on very funky bipolar settings, that we like to call them. And we steered into the ventral part of the VIM, away from the capsule, which would get you a side effect, and then below the VIM in the PSA or zona inserter or whatever you want to call it. But you can shape the field. You can make like an S shape and steer away from what we think are the ataxia fibers, and because that's the biggest problem, that they get ataxic. And then we ramped them up to 6-7 milliamps on bipolar settings, and that did the trick. It took us a while to figure that out, but we tried everything with them. And I think in our paper we also have a little image on how long it took us to program these patients. And I think the first patient was like 16 hours or something. Mm-hmm. So we spend a lot of time with these patients. The problem was we didn't.
Could be the confounder, right? That you probably didn't take as much time before, or
well, they had tried to get them better over years and years, sure. and then there's only so much you can do with these standard electrodes, and that's the problem of the directional electrodes, that you have so many options now. And we didn't have imaging back then. We didn't have, and we were not allowed to use any images, which made it so difficult for us, and which I think wasn't easy. we learned. So we gave Boston Scientific our settings once we had finished the trial, and then they came up with these weirdly shaped VTAs, and then we were like, oh wow, okay, we weren't aware of what we were doing there, but we found out clinically. And but now I actually when we have challenge and tremor patients, it takes me 10 minutes to get them really good, because I know I want to create that shape, and I plug them to these funky directional settings, and it really works. So it's really cool.
That's amazing. So that should certainly be, if it's published, if you show that S-shaped thing somewhere, that should be a good read for people. True.
We should definitely do that.
So it brings me to the next topic, that you also looked a lot into imaging, and one key, if you have these directional electrodes, and then they of course make it much more complex to stimulate, and that's why reconstructing them is much more important. So the technique that Peter Reinacher came up, and also the CT-based methods is so important. What's similarly important, and you looked at, would be like, let's say you do the fluoroscopy, how they are shaped, but would they still turn afterwards, right? There could be some tension probably in the wire, and then maybe over some months they would still turn by, let's say, 30 degrees. And I think you had a study that looked into that. Right?
Yeah, exactly, because that was the big question that came up once we had figured out how to depict the orientation. A lot of surgeons had the feeling, that they would continue to rotate. And we looked into that in our study here in St. Gallen, where I think we looked at 32 electrodes, where we compared the intraoperative X-ray, where we tried to hit the iron side and the marker anterior. So we knew that these were really anteriorly facing electrodes. And then we had a look at the CT scan, immediately after the surgery. And in some, we had longer follow-ups as well. And we actually found that they did not turn. So, but it really depends on the surgical technique. So if you give them a lot of twist, they might actually turn. And we just use the standard locking mechanism from Boston Scientific, and I'm sure the Medtronic one will work just as good. But there are some centers that use cement and a plate, and so I don't know if that is as stable as using the locking devices. But ultimately, and that's what all the other studies found as well. So there are quite a few publications on that now. It's not quite sure what happens within the first 24 hours. That really depends on the amount of twist you give and the surgical technique. But after 24 hours, nothing really happens anymore. Yeah. And I think that was an important finding for us, because we needed to know if you can trust the orientation when you do a study.
So perhaps the scientific concept that you currently stand most for could be your work on DBS for dental pain, where again you use directional electrodes in a very creative way in the thalamus. Could you walk us a bit through that concept, please?
Yes. So I think I have to start with or to tell you how we came up with this whole idea, and that was again in Vancouver. So Chris Honey did surgery on patients with pain, but when I went there and I asked him about it, he actually said he doesn't really believe in it. Okay. But I encountered 2 patients where it had actually worked. And one patient was a patient who got a battery infection, unfortunately. And so we needed to leave her off her stimulation for 6 months. And I got to know her very well because she was, with us for quite a while. And she had I only knew that she had facial pain, that's what they labeled her as, facial pain. And then Chris Honey always told me, or not always, he told me a story about one patient that he could never forget. And that was a lady. Again, he said she had some sort of facial pain. He did a VPM DBS on her, and it helped a lot. But then at some point the electrode broke and he wanted to take out the system. The pain had come back, and he pulled out the electrode and he caused a bleed. And she woke up with a hemiparesis. Oh. But the first thing she said was, "My pain is gone." Wow. And she got her motor functions back after like a day or 2, but the pain stayed away, and she ever since then is 100% pain free. Wow. So I thought that's really interesting. So I thought I was starting to get curious about the kind of facial pain they had. So I looked into their charts. And then I realized that they both had the same kind of pain, and it was neuropathic dental pain. They both had the same story with going to the dentist who did, some sort of root canal treatment. And then after a few weeks, they got this constant burning pain and so on. And the funny thing is, so I remember that moment. I was like, oh, wow, they had the same kind of pain. But the funny thing is, it was on a clinic day. So that day we had a patient walk through the door who had exactly the same story. And I went before she came in, I went to Chris and Honey and said, these 2 patients, the ones that worked, the only pain patients that worked, they have the same kind of pain. And that lady who's coming in now, she has the same thing. So he asked her in, and she told him about, the pain. And then he just looked at me and then he looked at her and said, you know what, we will have a treatment for you. It's called deep brain stimulation. And so that was the beginning of it. But then when she had left, we were like, okay, but now where do we put the electrode, right? So I asked the previous fellow, Josue, who's really very good with imaging, to localize the lead and the lesion. And it wasn't easy. One patient only had a CT. The other images were very old. So we found that it was somewhere in one of the 3 nuclei, the anterior pulvinar, the VPM, so the sensory thalamic nucleus, or the central medium, the CM. Yeah. And so we thought, and they just look like triangles next to each other. So I looked at them and I thought, should we put 3 electrodes in? Or I kind of recognized that pattern, and I thought, oh, well, that looks like, why don't we just put a directional electrode in and then just steer into each one of them? Yeah. And so I drew everything and then went to Grisani and said, look, I think we should do that. And he just looked at me and said, yeah, okay, let's do it. Okay, sounds like a great idea. Yeah. And so we did, and we did a blinded study on her. We put her on each of the settings for 2 weeks, and it was we saw the best effect with this stimulation in the VPM with some co-stimulation in the CM. But the moment I started to believe was when we put her on the off setting. And she called the next day to tell us, what, I don't like that setting. My pain is back. Okay. And so we realized, okay, that it really works and it's reproducible. And so that's when I got really excited about it. I still am excited thinking about it. So we operated on another patient, and it also works on her. And then we thought we should come up with a prospective trial, and we've actually we almost started it. But now that I'm going to London, we're going to do it in London now. So it's a little bit on hold, but we already, we've already spoken about that. This is going to be one of the first projects that I'm going to tackle there. So very excited about it.
Really cool. And you still think it is kind of specific to dental pain or to that, specific subform of facial pain, or would you say we don't know yet?
So we don't know yet on the one hand. On the other hand, I think it kind of makes sense that it's the CM and the VPM in the literature are the nuclei that are the ones that have been targeted with pain the most. So we did a whole literature search and all that. Sure. And there is quite a lot of evidence that CM or VPM stimulation works. Now in the thalamus, you have like this homunculus, and the oral part is the most medial part. And so it happens to be very close to the CM. And I think this is kind of probably the magic thing about it, or the good thing about it, the reason why it's working so well, because you have this sensory input probably from the teeth and the mouth in that corner where you can co-stimulate the CM, which also seems to be a good target. So maybe that is why it's working so well. And the further out you go, the further lateral you have to place your electrode, and the further away you get from the CM, and you will probably also cause, other sensory problems and so on. So I've thought about this a lot, but I think this could be one of the key reasons why it's working so well. Because they have different inputs. The CM is almost is like more the emotional pathway than the sensory one. So I think the combination is probably very good. But that's exactly what we want to study now and need to study. I think we need to make the next step now. And I guess, that if the story is, or the reason is, it's really in this sweet spot between the 3 nuclei. I mean, I find it so creative and brilliant to use that opportunity of the triangles with directional electrodes. It makes so much sense. But one question probably, my eyes would have is, you need to find that intersection point, right? So let's say if by accident you'd be in the CM, or, then you can steer all the way. So how did you do that with, Yeah. So again, I used Josue and his knowledge about tractography. And so we got really very high dense, like very good MRIs with DTI data. And then Josue ran all these calculations, and he was able to depict the nuclei based on tractography. I think he used lead DBS as well, and every all these tricks that you do. I don't know much about it. I just have to trust him, but he obviously hit it right. And so he segmented the nuclei based on tractography and then sent us the images. So he was in, New York at that time. So he sent it over, and then we based our planning on this localization.
Amazing.
But you're absolutely right. That's the next point. So I'm so excited, as you know, I'm going to London and I'll have Harith Akram there as well. And
similar
Josue,
hero.
and
Super.
Yeah. So
Great.
it's and Josue is we're still collaborating on stuff. So I think that's a key point to make sure that you can localize these nuclei as good as you can. Right.
Yeah, that's great. I think So speaking again about this creative way of targeting 3 nuclei in the thalamus, do you think there could be other indications where this could play a role? What comes to mind obviously is Tourette's with CMPF Y intersection that was described. Would that make sense as well, or do you see other indications where we could use the same concept to find out?
I think I haven't really. I don't have a specific idea where I would, whether I'm about to do it. But I think, the companies are working on these 16 contact electrodes, or the longer electrodes, the ones where you have directionality in the lowest and the most upper contact as well. And I think that I would love to use one of those in tremor. And go even deeper into the zona inserter and further up in the VIM. You could probably do a dual targeting of VOA and VIM and all these areas for the stonic tremor. It has all been done with the standard leads, but I think the directional electrodes do give us more opportunities there. I would really have to think about that a little longer. But I'm sure there will be other indications or other areas in the brain where they will become very useful. And since
you mentioned VOA and VIM, you could even think about Parkinson's potentially targeting VOA for the like the hypokinetic symptoms, and then tremor in the VIM, because you don't get them so close side by side. Probably anywhere else. I should think about this more before I keep talking. But it's certainly a very exciting concept. And then I guess again segues into the next big thing that I think you're really interested in is imaging. Using like image guided DBS, and you mentioned José Abesilas Chazin. I hope I pronounced the name correctly, but I'm a big fan of his work as well. He's as you say, one of the makes probably the most beautiful tractography images in the field, or one of them at least. Don't want to hurt anybody else, but I think he's using MR tricks, has these very high resolution pictures there. So and did a lot of cool work. So I did not even get that he was the fellow before you with Chris Honey, but I know he was all over the place, and been in contact with him a bit as well. So I think there was also, together with him, I remember there was a study in JNS this year where you looked at optimal sweet spots and tracks for essential tremor as well, going into that same, direction, but with imaging. What did you find there?
Yeah, so these were actually our tremor patients from the study where we had exchanged the electrodes. So we found that we were able to give them better tremor control, but now we wanted to see what are we actually stimulating, what makes the difference. So he simulated the VTAs of the standard electrodes and the VTAs of these funky directional setting electrodes. Then we basically found that they were both stimulating the cerebellothalamic tract, but that the directional settings also stimulated the pallidofugal pathways, which is not what you would have thought, right? Or not what you would have thought of at first, at least. We were able to stimulate deeper. So, and I think that also makes a difference. And with the directionality, I think you can steer away from ataxia a little bit, or definitely better than without directionality. So, so we stimulated an additional pathway with them. And I think that's a nice explanation on why we achieved what we achieved in those patients.
Very interesting. And I did not realize that, because you said you would not have thought that, but I guess Rick Helmick would have thought it, right? With the dimmer switch model with, the idea there is to, if I'm correct, that basal ganglia input essentially switches to tremor on or off, and then the cerebellar input codes more for the intensity of the tremor. I might confuse the two, I'm not 100% sure, but right, so there it would make a lot of sense that, and you have tremor response in the GPI, right?
Yeah,
so
absolutely. Yeah.
I'm not even surprised, but it's great that you showed that, and I didn't realize it. So very cool.
Yeah. I thought that was very interesting. Yeah.
I did interrupt you though. So did you want to say?
No. I think that was all I wanted to say about that.
Following up on the image-guided story, you also worked with companies to look into like evaluated segmentations of thalamic nuclei that are made by software such as BrainLab and others, or probably BrainLab mainly. Would you conclude that the currently available software, let's not speak about a single manufacturer, but what is on there is helpful as a neurosurgeon, or helpful post-op for programming, or not helpful at all?
No, I think it is definitely helpful, but you really have to be careful. You need to understand its limits. And so the first thing, the segmentation, I think, no matter what software we're using, you need to be aware it's not 100%. And when you do the targeting, we're targeting on a below 1 millimeter level. So I always do my planning without the colorful images, but I like to switch them on. Yeah. And then it sometimes gets me to think. So the best example is always the tremor. I do coordinate-based tremor targeting, and I don't have images where I really see the VIM. There are some now. I'm eager to use them, but at the moment I'm not. And then sometimes the software would show me a very asymmetrical VIM localization. And then if you zoom out and you look a little bit closer at the anatomy, you realize, oh yeah, that patient has a very asymmetrical anatomy. Yeah. And then you look at the red nucleus and it's really 2 millimeters off. And then I now adjust my stimulation. We actually published on that case, one of the cases. It was the first one where it was made such a big difference. And now I adjust my planning based on that. I mean, you can see it without the colorful images, but it's much easier to see. And so it always makes me think. Also in SDN, if I'm completely somewhere else, I have another look. But I always trust my raw data planning. The one thing you have to keep in mind is that it can only be as good as the images that you feed it. If you put in crappy images, you can't expect anything good. And then I think it's really great for programming. You can see the anatomy, you can see the relation of the nuclei and the fiber tracts and everything. So I like to look at these images with the neurologist when they have a challenging patient. We sit down together, we look at the anatomy, or I do programs, some patients myself, when there's a specific question like, capsule side effect, you look at the image. You localize the electrode, the orientation. It literally takes you 5 seconds to program that patient or reprogram that patient, which would have taken you ages if you had to do it black box trial and error clinical testing. So that I really love it for that. And it doesn't matter, if the electrode is 1 millimeter to, or if the SDN is segmented a little bit wrong. All you need to know is in relation to the SDN or to the electrode, where is the capsule? What contact is facing the capsule? What is steering away from it? So which one do I have to use? And also the depth of the whole thing. So I always like to adjust the software or the segmentation based on what we found intraoperatively. So that is a bit time demanding, I have to admit, but I really like it, and I think it's worth putting in the effort, and it really helps with it.
I guess that's one key point that you said, that even if these models are not 100% accurate and maybe a millimeter here or there off, millimeter can be a lot, right? Still, Still, they might be really helpful if it's just about making it easier to create a 3D image in our head, about the scene. So I totally agree with that. We just published a software for intraoperative visualization where the microelectrodes are, where, you have the microelectrode recordings and then the anatomy. And I said the same thing all the time, like as somebody that did microelectrode recordings in the OR, it can just be helpful to, roughly know, am I still in the striatum, or, is this the gap, or, am I, already in the pallidum, and so having that additional, like, even if it were not 100% accurate, it would help me to get,
we published on that with, we did exactly publish on something like that with the team in Freiburg with Peter. It was Peter's idea to do it, to have the images on the screen while we're going down.
Great point. And we did cite that study, I'm sure. So I've seen it. So, absolutely. I didn't make the connection now, but yeah.
And we what we found was essentially, if for the experienced members of the team, and I wasn't experienced at that time, they thought it was nice, but it wasn't really helpful because they still went did what they always did. But for me as a young resident, it was so helpful. For the neurologists, I think it was so helpful, and it was really great because we could really discuss about what was happening and what was going on. So I think it's a great teaching tool, and it helps to put everyone on the same page. And so I guess the only issue was it took a lot of time to set up, but I'm sure there might be quicker mechanisms now, and then it's a really great addition into the OR.
So if we spin this further, so you have BrainLab now that gives you the segmentations, but I've just spoken 2 days ago with a young neurosurgeon at BU Medical Center here in Boston. Name is Pratik Rohatgi, and he uses a software by Pierre Dehaze, who's also behind the cranial vault software, that apparently gives him a target. It's essentially apparently using the same idea to, instead of saying this is the anatomy, it would give you the sweet spot. And he also said he didn't trust it, but he still always looks at it, right? So would you agree? Would that be, probably you wouldn't trust it, but would it be?
I wouldn't trust it until I've studied it, I mean, you cannot trust these kind of things, but I think what would be great if you could feed your own data into it, and if you have your own sweet spot to feed it into the planning. But I think they're working on stuff like that. It's coming. It's very exciting, but I would never trust something like that. But I would love to prove that it's correct, and then you can use it and feed it into everything. For sure.
Great, Marie. We just met in Boston, where I learned that you also are about to leave St. Gallen, where you currently head the stereotactic program. And you're, as you mentioned, you're about to move to London, and that's really exciting. And you also already mentioned that you'll work on MR-guided focused ultrasound. I think one reason you were in Boston was to also look at the setup by Reese Cosgrove here at the center at the Brigham. And I'm sure you have great plans. I mean, London is such a, it's a cradle of stereotaxy maybe in Europe. So it must be very exciting. Can you tell us a bit more about, what you plan, what are the next things? A few things you already mentioned, but beyond that.
I'm also very excited. I mean, I'm so much looking forward to working with the great team there with Ludwig and Harris, and I mean Patricia Limazar. It will be next door. It's just amazing. And so we went to Boston because London has they just got the high focused ultrasound installed, and we wanted to see how someone with a lot of experience like Reese Cosgrove does it, and now we're going to start with the tremor patients in London, obviously, but of course we have other plans as well, and they're really not very concrete yet. But like I mentioned before, we are all hoping that the high focus ultrasound might be a good way to treat patients like psychiatric patients. And might actually make it a little bit more or easier to get these patients interested in having surgery or not surgery or whatever you want to call it.
Yeah.
And I personally, I can't wait until I found the sweet spot for dental pain and can make a lesion, because I really think lesions and pain go very well. So, and then the nice thing about the high focus ultrasound is that you can do these randomized studies where you or these sham control studies where you put them into the machine, but you don't turn it on, and then next time you turn it on, or the other way around. And so it's because the biggest problem with pain obviously is the placebo effect, and also the lesion effect when you put in an electrode and all that. So I think it gives us new opportunities to work on other indications outside of tremor, which obviously is a very good indication for focused ultrasound.
Great, exciting times. Sorry.
Yeah. No. And then we have a whole bunch of other things that we're going to work on with DBS, of course, but sure. I don't think we have the time to go into all of that.
Watch this place. Yeah, we'll see. So let's maybe briefly hear your executive summary about lesions versus DBS. What will MR-guided focused ultrasound bring, or in general, lesions versus deep brain stimulation?
So for me, I think it's more like a complementary therapy rather than you have to choose one over the other. I don't think it's competitive. It'll allow us to tailor the therapy a little bit more down to the patient. Both therapies have their pros and cons, and I think it's the responsibility of the surgeon to know about them and present them to the patient so they can choose whatever they feel is best for them, and of course to maybe give recommendations about what you think. So I would always, if a bilateral tremor very strong on both sides, young patient, I would still go for DBS, but older patients, very unilateral, I think high focused ultrasound is a great therapy. And it brings me back to to what we said before. You have patients coming in now and asking for high focus ultrasound because they heard that there's this non-invasive method of treating their tremor, and they would have never dared to come in to ask for DBS. Yeah. But there are patients, and if they want focused ultrasound, we're happy to send them to Zurich to have it. But a lot of them are actually change their mind and say, oh yeah, but DBS, that does sound like it has some advantages. And obviously the biggest advantage is that you're not burning a hole in the brain, and you're not, everything is reversible, I think the amount of side effects that you get with focused ultrasound is still quite high.
Yeah.
And bilateral lesions are, not really, or we're not quite sure if we should do that, or the data isn't we don't have enough data on it yet. So I think, there are reasons to go for DBS and there are reasons to go for focused ultrasound, but it's just another nice tool to have. But if we're honest, it's nothing but it's just a radio frequency ablation, but it just sounds so much better. It's just. And
I guess that was also the question. You still answered that. It is even the classical lesions. DBS is more forgiving. I guess you can adjust more. It's more reversible and so on. Lesions are more permanent. But then I guess Marwan Harris always says DBS gives you the umbilical cord. You're tied to your neurologist afterwards, right? And the lesions would be a one and done thing. So I like how you see it. Another tool, and that's great. So more choice is, I guess, always good.
Yeah, and there are a lot of patients who just don't want to have wires in their brain and who don't want to be controlled by a machine or by a neurologist. So I totally understand that some patients would want to prefer to have the lesion. Yeah.
So let's wrap up with some rapid fire questions. I know I've taken a lot of your time already, but so you can, if you want to answer as brief as you can. Can you tell us about some eureka moments that you may have had in your career?
So I think I mentioned one already. I think it was that moment when I realized these two pain patients had exactly the same kind of pain.
Yeah.
And when I saw the pattern and that we could put a directional electrode in. And then the next one, when this lady called and she said on her off setting, my pain is back.
Mm-hmm.
And I was like, oh my God, I think this is really working. Awesome. Mm-hmm. So that's just, I think, I'm sure there were a few more, but that's the one that really got stuck in my head.
Cool. Did you ever think this was a complete waste of my time?
Actually, I don't think I ever thought that. I think I was always able to get to see something good in everything. And I always try to live that way, to always see the sunny side in everything. So no, I don't think I've ever, maybe a movie where I just thought, okay, let's just leave. Yeah. I've actually left the cinema. But
since we talked about like academic success, did you have ever like failures or things where you said, this did not work out?
Absolutely. But you know what? I think my failures are the things that you learn most of. And I wouldn't say I embrace failures. It's not like I'm working towards having a failure, but I've really learned to be really okay with having a failure, and you need failures to move forward.
Yeah.
You just need to draw the right conclusion, and it's always hard if something didn't work and you've put so much time and effort in it. But I think if you sit down and you think about it and you draw the right conclusions, we can spend a whole episode talking about my failures that have then turned out to become success, really. So no, I think I don't think I would ever look at the failure as something that was a waste of time. It was important. Yeah.
What do you think about the general future of the field of neuromodulation? What will happen? What will come? What are the next big things?
Oh, wow. I think it's very bright, and I can't wait to see what's going to come. I think the next things will be closed loop and sensing. I can't wait to see, what we can do with all that. I'm also excited to see the next models of directional electrodes. Can't wait to see what we do with the focused ultrasound imaging, what's coming from that end, all the software, they're improving the softwares and everything. So I'm very excited to see what's coming, but I have no idea. It's just so much is happening, but it's great.
It's an exciting field at the time, I think. I agree. Do you see missed opportunities or things we should be taking as a field, but are not?
I think that's something we've already talked about. Like, we should collaborate more with other specialties like psychiatrists, pain specialists, because the most challenging thing, and the reason why I think maybe the DBS or the therapy isn't working that well, is that they're really difficult patients, and we've learned who of the Parkinson population are the 10% that you can help with a DBS, but who of the pain patients are the 10%, who of the psychiatric patients are the 10%. And we can't do that without, the specialists in that field who are dedicated to try to phenotype them. And I think we haven't done enough there. And also, I think we need more prospective studies. And I wish it wasn't that expensive and tedious and so much hard work and would take so long to all the bureaucratic hurdles that you have to take. But I do think, especially again for pain, we need to prove in studies that what we think is working is actually working.
Yeah. Any advice for young researchers entering neuromodulation as a field of surgery? Yeah.
I think if you chose neuromodulation, you're in the right spot. If it's something you really want to do, I mean, within neurosurgery, at least, I think functional is the very, or has a bright future, and a lot is happening. It's very exciting. I think also as a woman, it's very elective. So if you've made it that far, and to know that this is what you want, go ahead, do it. It's just getting there. That's the problem.
That's the problem. Maybe, do you have advice, especially for women entering neurosurgery or science? get there?
I think you need to be aware that it's the residency is very tough, and that you really have to be sure if you really want to do it. So for me, it was I had to learn who I am first and what I really want in life. And then I think when I kind of got a good idea of what that is, I realized that functional neurosurgery was what I want to do. And then everything is easy after that. I don't want to disencourage anyone to do neurosurgery, but you really have to want it. Yeah. And you really have to be ready to suffer and kind of have to enjoy suffering a little bit, or not just a little bit. And you have to be aware that, you have to ask yourself, do you want to have a family or not? But there are ways to make it happen, and it is possible within neurosurgery. It's just not maybe the most obvious way. But I truly believe if you really want to do it, if that's what you want, you need to do it. You will not be happy. And then the opportunities will come and the way will present itself. Yeah. And I kind of feel like this is what happened in my life. I always listened to my gut when it came to the big decisions. And although I wanted to do neurosurgery and I couldn't see a way of doing neurosurgery, because I definitely also want to have a family. I never saw it, but I always followed my heart and listened to my gut feeling. And now I think I have found a way where ultimately I can have both in functional neurosurgery and be very happy, in my daily life and the job. But you have to, I think you have to be very honest to yourself. And if you feel like, if you do it because your parents think you should become a doctor, stop right here. Stop, turn around, do something else. If you do it because you think you can make good money, I mean, go into computer stuff and other things. But if your heart tells you that this is what you want to do it, and life will find a way for you.
Great words. Love that. So is there something you would love for somebody to work on, but you yourself lack the time? So something you think this should be done?
I think it would be great if we could find not just symptomatic control, but like disease modifying, if you could go into more disease modifying therapies, so gene therapy and all these kind of things. So this is something that I just don't have the knowledge and I don't have the education.
Or you just want early retirement to get you out of your job. I'm
true. I'm kidding. I never thought about that. Okay, I take it back. Let's
no. Don't worry, it won't happen. You are young.
No, it would be.
There will be other diseases, and yeah.
No, I would happily retire if someone found the cure for all these diseases. But I think this is something I would really love to see happening, and at least that we get a little bit like some idea. And that we can treat the cause rather than just the symptoms. And I hope that there are clever people out there who are working on that. I'm sure there are. But this is something I think is super interesting, but it's just nothing that I think I can ever do. So, yeah.
Great. Anything else you would like to talk about or would have loved to cover? I know we covered a lot, but anything else before we stop?
No, I think we really covered a lot.
Enough.
It was a very great honor to be part of this, and a great pleasure.
The honor is mine. Thank you so much once more. This was really amazing. Thank you for sharing your wisdom and taking the time.